So today's topic is renal implications of anti-diabetic drugs. Good evening to all of you. Epidemiology, CKD is common and it involves about 20 to 30% of the patients with diabetes. In fact, CKD in diabetes itself is renamed as DKD, diabetic kidney disease. So as you know, it is very important that we manage the CKD in diabetes. Leading cause of end-stage renal disease in United States as well as in India is diabetic kidney disease, and 25 to 30% of the patients with DKD may not have a proteinuria. So why in CKD diabetes management is different? This kidney metabolizes about approximately 25% of the circulating insulin. The renal clearance of insulin is reduced. There is increased risk of hypoglycemia and lactic acidosis, concurrent anemia, and secondary hyperparathyroidism, which influences the long-term outcome. And there is increased risk of cardiovascular disease. So managing diabetes alone is not that in diabetic kidney disease. So we know the KDIGO staging of CKD, various stages, glomerular stages, and KDK classification. So as a nephrologist, to use oral anti-diabetic agents. So when to use and how long to use and with what GFR? What is the risk that the patient is having with your oral anti-diabetic drugs in view of hypoglycemia? Can this oral anti-diabetic drug offer renal protection? Can it retard the progression of CKD? Can it reverse renal dysfunction? So these are the things which come to a nephrologist's mind when you are managing diabetes in kidney disease. We know the DKD pathogenesis, which is hemetabolic and hemodynamic alterations, which trigger a number of cell signaling cascades, activation of key transcription factors, and in response, there is tubular epithelial cells, podocytes, and mesangial cells, which produce chemokines, growth factors, and profibrotic cytokines. And there is a loss of podocytes, endothelial dysfunction, glomerular basement membrane, and tubular injury, which lead to proteinuria, apoptosis, progressive fibrosis, and loss of glomerular filtration rate. And the CKD stages, it progresses. So what are the challenges with renal impairment and oral diabetic drugs? So we know the first line agent, which is the metformin, the risk of drug accumulation with sulfonylurea, hypoglycemia, thiazolidinediones causing fluid retention, alpha glucosidase inhibitors, again drug accumulation, SGLT2 inhibitors, which has a mechanism which is dependent on the renal function, insulin, which can cause impaired catabolism and clearance of exogenous insulin, and there can be a difficulty in dosing of insulin. So the active metabolites of many oral anti-diabetic drugs are renally excreted, and there's increased risk of hypoglycemia. So as you can see in the slide, as the GFR worsens or as the CKD stage progresses, especially in elderly patients more than 70 years, there is increased risk of hypoglycemia with OHA. In this study, they have compared sulfonylurea with insulin-induced hypoglycemia. So as the stage of CKD increases or as the stage of CKD progresses, there is increased risk of hypoglycemia. And what is the difference of HbA1c target in a patient with diabetes and kidney disease? So an HbA1c of less than 6.5 does not hold good for a CKD stage G5, whereas in a patient with glomerular stage 1, an HbA1c less than 6.5 will hold good. So this is in the background that the patient should have an individualized HbA1c target, and it can range from less than 6.5 to 8%, depending on the severity of CKD, micro and macrovascular complications, depending on the age, life expectancy, resources for hypoglycemia management, hypoglycemia awareness, the propensity of treatment to cause hypoglycemia. So this is the range of HbA1c when you are managing a patient with diabetes with chronic kidney disease. So metformin in type 2 diabetes, it is contraindicated in renal dysfunction. Some studies have come up with creatinine levels more than 1.5. You cannot give metformin, and metformin should not be initiated in patients with more than 80 years of age. So a practical approach to metformin prescribing in the setting of chronic kidney disease will be when the eGFR is less than 30 ml per minute per 1.73 meter square, do not use metformin. There is no doubt about it. If the patient eGFR is more than that, if the patient is in CKD stage 3B, 32 less than 45, you do not initiate the therapy, but if the patient is already on metformin, you can reduce the dose by half in CKD stage 3. In more than 90, you can use metformin. Immediate release preparations of metformin, particularly in the evening dose with meals, is recommended when you start, and after 7 days, you can increase the dose. So newer evidence is coming up that metformin may be of benefit even in advancing kidney disease. And metformin also, there are challenges in advancing chronic kidney disease, but it has its own promising therapeutic strategies as well. And there is risk of fatal and non-fatal lactic acidosis with metformin use in type 2 diabetes. The risk of lactic acidosis in the study, they have pooled data from about 347 trials. It revealed that the incidence of lactic acidosis per 1 lakh patient years was only 4.3 cases in the metformin group and 5.4 in the not metformin group. So whether we need to look onto the lactic acidosis component along when we use metformin is still doubtful. Because of the risk of lactic acidosis, we try to refrain by starting the patient on metformin. So the algorithm proposed in CKD with diabetes for metformin dosing is as follows. eGFR less than 30? No. You should not use metformin. If the patient is already on metformin, you need to stop metformin. If the eGFR is more than 60, you give immediate release preparation. Initially, you start with 500 milligram with evening dose or 850 once daily. After a week, you can increase the dose again by 500 milligram until the maximum dose. And if GI effects or side effects of metformin are there, you can give extended release. This is if the eGFR is between 45 to 60. If the eGFR is 30 to 44, you need to initiate at half the dose of metformin if you're planning to start the patient on this first line agent and titrate upwards to the half of maximum recommended dose. And you need to monitor the vitamin B12 if the patient is on metformin annually. For if the patient is annually, you need to monitor the vitamin B12 if he is on metformin for more than 4 years, or he is at risk of vitamin B12 deficiency. You need to monitor the kidney function annually if the eGFR is more than 60, and if the eGFR is less than 60, at least every 3 to 6 months, you need to monitor the renal function test. And if the renal function test is showing an eGFR more than 60, you continue the same dose. And 45 to 59, you may sometimes need to reduce the dose, or you may continue the dose. 30 to 44, you need to reduce the dose by 50%. So metformin use below eGFR of 30 ml per minute is off-label, and it should be considered only if the level of insulin resistance is too high. Coming to sulfonylureas, glibenclamide has active metabolites that are excreted in the urine, and it accumulates in patients with impaired kidney function. Glimepramide is primarily metabolized by the liver with renal excretion of active metabolites. Glipizide and gliclazide are metabolized by the liver and primarily excreted in the urine as inactive metabolites. So sulfonylurea in combination with insulin is associated with increased mortality compared with the combination of insulin and metformin in a retrospective nationwide Danish study. So in long-standing diabetes, as you know, there is a beta cell failure and insulin secretagogues will not work. Then regarding the insulin therapy, intensive glycemic treatment in both type 1 and type 2 diabetes, it reduces the progression of early diabetic kidney disease, but there is no data to prove the specific nephroprotective properties of insulin therapy. And Pills et al. Analyzed 1,415 healthy non-diabetic participants, and that insulin resistance or reduced insulin sensitivity measured by hyperinsulinemic euglycemic clamp is associated with a greater risk of albuminuria. So whether insulin can prevent or reduce urinary albumin excretion independently of blood glucose levels is yet to be clarified. So if you are using insulin, the recommendation on dose titration is as follows. If the GFR is more than 60, no reduction in the total dose titration. If the GFR is between 15 to 60, there is 25% reduction in the dose. And if the eGFR is less than 50, there is 50% reduction in the dose. So in type 1 and type 2 diabetes also, you have a dose reduction like more than 60. Type 1 diabetes, you continue 1 unit per kg per day. Type 2 diabetes, 0.5 kg per 0.5 unit per kg per day. 60 to 15, you reduce the dose by 0.75. Less than 50, it becomes 0.5 in type 1 diabetes. And type 2 diabetes, 60 to 50, it is 0.3 to 0.4. And the A1C targets, if the GFR is more than 60, the A1C target is less than 7% when you're using insulin, and less than 60, it's between 7 to 8%. Coming to thiazolidinediones, it is completely metabolized by the liver. It is associated with heart failure and formation of edema. Bladder carcinoma is a controversy. Renal excretion of DPP4 inhibitors as a clinical significance. The linagliptin and teneligliptin are partially or minimally excreted via the renal route, and there is minimal change of plasma drug concentration or no change at all, and the same dose need to be given. Whereas sitagliptin and vildagliptin, it increase the plasma drug concentration when there is renal impairment, and a lower dose provides an optimal efficacy. So the dose reduction should be there for sitagliptin and vildagliptin. Sita, if the eGFR is more than 50, you continue as 100 milligram OD. Between 30 to 50, 50 milligram OD, and less than 30, it is 25 milligram OD. Linagliptin is 5 milligram once a day for all stages of renal impairment. Vildagliptin also, more than 50, you can give 50 mg BD, and less than 50, you can give 50 mg OD dose. So this is the DPP4 inhibitors. See, linagliptin 5 milligram OD, you can give at any stage of renal impairment, which is safe. So until 2015, there was scarcity of studies analyzing the nephroprotective effects of hypoglycemic drugs beyond their glucose lowering effects. Now there is a major shift after 2015, and we have another major pillar after years of stagnation. The strongest evidence yet is on SGL2 inhibitors, which are renoprotective, and kidney is the main site of action of SGLT2 inhibitor. It basically weighs the sugar in urine by blocking the sodium coupled glucose reabsorption in the proximal tubule. They are renoprotective. It increases the distal tubular sodium delivery, stimulates the tubular-glomerular feedback, increases afferent arterial tone, and decreases the intraglomerular pressure. In addition, it decreases the weight and blood pressure. Decreased sodium absorption could also possibly affect the proximal tubular cell energetics. So SGLT2 inhibitor reduces the albuminuria, slow decline of eGFR, and there is a nephroprotective mechanism, but it is not suitable at when the eGFR is less than 20 ml per minute per 1.73 meter square for dapagliflozin. So we have the DAPA trial. We have already heard a lot of talks on this dapagliflozin. It reduces the end-stage kidney disease as well as renoprotective mechanism, reduces the albuminuria as well as the cardiovascular deaths. So we have come across the Empiric Canvas, Declare TIMI, Credence, DAPA CKD, DAPA HF. So new cardiovascular metabolic agents for type 2 diabetes. These are after the 2015. So we have EMPA, CANA, DAPA, liraglutide, and semaglutide. All reduces the cardiovascular events and nephropathy. But regarding the retinopathy, it is still not that clear. So in diabetes, we require a comprehensive care recommendation in patients with CKD. Forget not the exercise, nutrition, and smoking cessation, which is the base of the pillar, a glycemic control, blood pressure control, lipid management, RAS blockade, SGLT2 inhibitors, and some patients may require antiplatelet agents. So treat patients with type 2 diabetes and CKD with an eGFR more than 30 with an SGLT2 inhibitor. For glycemic control, metformin and SGLT2 inhibitors when the eGFR is more than 30. For DAPA, you can go as below as up to 20, more than 20 ml per minute. SGLT2 inhibitor is recommended for patients with type 2 diabetes and CKD, and RAS inhibitor is recommended for patients with albuminuria and hypertension. So CKD progression in type 2 diabetes, the standard of care, we need to tackle not only the metabolic parameters, but also the inflammatory and fibrotic factors in kidneys. MR overactivation is thought to contribute to inflammation and fibrosis. Then the hemodynamic AC inhibitors and ARBs, thiazide like diuretics, calcium channel blockers, and SGLT2 inhibitors. So we have steroidal MRAs and non-steroidal MRAs for inflammatory and fibrotic factors. And we have non-steroidal MRI Findrenol, which is a new kid on the block. And the mechanism of action is it induces the conformational change within the mineralocorticoid receptor. It works to decrease the inflammation, fibrosis, and it is FDA approved. It reduces the risk of kidney function, reduce incidence of kidney failure, reduce cardiovascular death, reduce non-fatal heart attacks, and reduce hospitalization for heart failure in adults with CKD and type 2 diabetes. So when you consider glucose lowering medication after metformin and SGLT2 inhibitor, the question is what next? You start on the first line agent metformin, second is SGLT2 inhibitor. So what next? The preference, comorbidity, and other characteristics come into play. So if you're thinking about to avoid hypoglycemia, you can add a GLP-1 receptor agonist if the blood sugar is still not under control, GPP4 inhibitor, thiazolidinediones, and alpha glucosidase inhibitor. If you are concerned about the potent glucose lowering effect, then your choice will be a GLP-1 receptor agonist or insulin, GLP-1RA or insulin. Then if the patient has a high risk of atherosclerotic cardiovascular disease, then GLP-1RA. Fluid overload, again GLP-1RA. If the eGFR is less than 15, you can use the linagliptin, insulin, thiazolidinedione, sulfonylurea, or alpha glucosidase inhibitor. If the patient is not affordable, low cost, if you are concerned about that, sulfonylurea, thiazolidinediones will be an option for them. And weight loss, again GLP-1 RAs, oral medications, all these are oral medications except for the insulin. Yeah. So anti-hyperglycemic therapies in patients with diabetes and CKD, the recommendation by KDO is in patients with type 2 diabetes and CKD and eGFR more than 30, the metformin should be used as first-line treatment for hypoglycemia. And in patients when the eGFR is more than 30, recommendation also includes an SGLT2 inhibitor in anti-hyperglycemic treatment regime. So the dose titration guide in CKD patients is like glipizide. When we are using, if the eGFR is less than 30, you use with caution. Climiprid, less than 30, you avoid the use. 5-glutathione, no dose adjustment. Metformin, it is controversial, but we know less than 30, do not use. Acarbose, if the serum creatinine is more than 2, avoid the use. Migletol, if the eGFR is less than 25 or serum creatinine more than 25, avoid use. Then SGLT2 inhibitor, you can use canagliflozin up to 45 to less than 60, and less than 45 you avoid use. Dapagliflozin, if the eGFR is less than 20, it's not 60, it is less than 20, you avoid use. Empagliflozin, again, less than 45 you avoid. Up to 30 is okay. Exenatide, eGFR 30 to 45, use caution. Liraglutide, there is no dose adjustment, but caution when you are starting or titrating the dose. So the comprehensive care guidance for CKD in type 2 diabetes, as we mentioned already, includes a lifestyle therapy and first-line therapy with metformin. When the eGFR is less than 45, you reduce the dose. Metformin, if the eGFR is less than 30, you need to discontinue. And dialysis, definitely you need to discontinue. And along with metformin comes the SGLT2 inhibitor. If the eGFR is less than 25, you do not initiate, and dialysis, you need to discontinue. So you add on the additional drug therapy as needed. GLP-1RA, insulin, thiazolidine, sulfonylurea, alpha-glucosidase inhibitor, DPP-4 inhibitor, which is guided by patient preference, comorbidities, eGFR, and cost. So the considerations for glucose medications in CKD: metformin, if the eGFR is less than 30, you need to stop. Insulin has a prolonged half-life. Thiazolidines may cause volume and bone issues. SGLT2 inhibitors are less efficacious, uh, but now we have studies when the eGFR is less than 45, it becomes less efficacious. DPP-4 inhibitors are safe, and most of them require dose adjustment. GLP-1 receptor agonists are also safe in advanced CKD, except for exenatide. So to conclude, diabetes is the most common cause of end-stage renal disease. DKD is 1/3 of the patients is without proteinuria. Modification of anti-diabetic drug is required with progressive renal damage. Insulin therapy is possibly safest in renal failure. ACE inhibitor or ARB inhibitors are the cornerstone in the management of hemodynamic alterations in the pathogenesis of DKD. Comorbidities like anemia, secondary hyperparathyroidism are to be treated for better long-term outcome. Thank you.